AML Hub podcasts, brought to you by Scientific Education Support.
Hello and welcome to the AML Hub podcast. Today we'll be hearing from Arnon Nagler from Tel Aviv University, Israel.
Thank you. So the question is that we will discuss today is whether MRD dictate the transplant in AML. So we all know that measurable residual disease and MRD is very important factor, prognostic factor for treating AML, both conventional AML treatment and also in transplantation. All started in ALL, as we know, and but moved later on to conventional treatment of AML and then to transplantation. And it does not matter if you assess MRD by flow or by molecular means or by next generation sequencing. The MRD dictate transplantation outcome. So patients that are MRD positive pre-transplantation have a much higher relapse rate post-transplant compared to patients that are MRD negative. And this is translated to a worse leukemia-free survival and overall survival. So patient MRD negative pre-transplant doing much better with lower relapse rate and better overall survival and leukemia-free survival. So we looked on this in the acute leukemia working party with various studies. We looked on myeloablative and reduced intensity, and we show that in both cases, MRD is important, but in patients that are young and MRD positive, below the age of 50, you should come with myeloablative conditioning. We looked on this not just in sibling and unrelated transplant, but we looked on the MRD significant for transplantation in haploidentical transplant, which is increasingly being performed for patients with AML, and we're able to show that MRD is an important prognostic factor for the haploidentical transplant. So again, patient MRD negative have lower relapse rate and better overall survival and leukemia-free survival. We looked on this in cord blood transplantation, the same, and recently we looked on even in patients that received unrelated transplant for AML and post-transplant cyclo, and in a paper that just presented at EHA, we were able to show that in patients that are MRD negative, again, while receiving post-transplant cyclos, they change the biology of transplantation because it upregulates T regulatory cells and knock down for the first months post-transplant NK cells. Again, patients that are MRD negative pre-transplant are doing much better. So the question is if the field is ready for changing the indication for transplant or trying to achieve MRD negativity in patients that fail to achieve MRD negativity pre-transplantation. And I would say that the field is not ready for changing the transplant in the patients that are MRD positive, the technique of the transplant, and also after 2 courses of chemotherapy, I would not, the field is not ready in AML for not going for transplant. In ALL, in the opposite, if a patient is positive pre-transplant, we have now monoclonal antibody that we can give, like blinatumomab, the BiTE antibody, to achieve MRD negativity. But in AML, one, we don't have such antibody. Second of all, even this ASH, this EHA, Russell from UK presented data with the AML 16 and 18 UK studies that in patients above the age of 60 with AML that received reduced intensity conditioning, which was 15% of the patient, the allogeneic transplantation helped patients that are either MRD positive and MRD negative, and also that in patients that are MRD positive after first course, if you give the second course and they become MRD negative, results are better. So I would say that you should try with 2 chemotherapy courses to achieve MRD negativity, But if you are MRD negative, if you are still MRD positive, I would still go for allogeneic transplantation because it helped also this patient. Maybe according to our data, if the patient is below of age of 50, and he have no comorbidities, I would give myeloablative conditioning and sure after transplant to all high-risk AML patients, either by mutation or chromosomal abnormalities or MRD positive, I would give pre-transplant, I would give maintenance and either preventive or prophylactic therapy if I can give it.
Thank you for listening to the AML Hub podcast. We would also like to thank our supporters, Genentech, Roche, AbbVie, Amgen, Novartis, Bristol Myers Squibb, Janssen Oncology, and Jazz Pharmaceuticals.
AML Hub podcasts, brought to you by Scientific Education Support.